But here's what I'm going to try and tell you. I think there's 4 things that need to be part of any treatment program. How you achieve those 4 things, there's a lot of latitude. And you got to pick what works for you. I'm not going to say one program's right and another one's wrong. But what I am trying to say is if you don't have these 4 pieces, your chance of success is incredibly small. And okay, so once again, my mantra, anybody can get healthy. Okay, here's the first step. You heard Lynn talk about it. It's such a duh, it's underrated in terms of its importance. Somebody who thinks they should stop is not likely to succeed. You know, if I'm there because, I want to get into drug court and the judge said do this, sorry, those people don't do well. You know, if I'm here because I don't want to get a divorce and my spouse says I should do this, nah. If I'm here because I'm spending too much money, it doesn't work. I actually tell people who come into my office that, you know what, you're not ready yet. Go away. Come back when you're ready, because I don't want you to conclude that what I have to offer won't work, because someday you're going to need it and you'll be ready. To start prematurely actually is worse than nothing. I'm not trying to say don't try everything, but you gotta know, you gotta take the right steps at the right time. Once again, I'm gonna keep repeating myself, 100% cessation of withdrawal symptoms, both initially and until the healing is completely done. Because anything less than 100% allows craving and distorted thinking to continue, and where there's craving and distorted thinking, there will be use. Can't tell you exactly when, but there will be use. And once there's use, boom, you're off to the races. Sadly, probably a lot of you know that. Okay, number 3. I'm biased, I'm a psychiatrist, but just listen to me. I think this makes sense. A lot of people who I see, and I see people, but by the time they get to me, they've done a lot of damage. And most of them really are under a lot of pressure from themselves and others to get things done. And one of the things I find at least half the time, if not substantially more, is that people, okay, they tried it for whatever reasons, but what they would say to you, same thing, I tried Roxy's, Oxys, Percocets, heroin, I was in love. Okay, all right, what do you mean you were in love? For the first time in my life, I wasn't nervous. For the first time in my life, I understood what a chilled out person really feels like. For the first time in my life, that I suddenly had a more optimistic outlook on life, or I could focus, or what I hear, oh, could I clean the house like nobody else could? Whatever makes sense. Some psychiatric problem, probably genetic in origin, no fault of the person's, suddenly seems to be compensated for, and the person goes, I love this drug because look at what I can do. Ask anybody who's used opiates, that lasts for no more than 45 days. And then what was so wonderful, not that it really was, but what seems so wonderful becomes terrible. It's now worse than ever, and oh, by the way, you're now addicted. The other thing, Lynn alluded to this, unfortunately not done very often, you need therapy. It can be given on lots of levels. A lot of people out there know what they're doing. Unfortunately, even more have no clue. So pick carefully. You've got to use therapy to be able to identify when you're not thinking clearly, when the craving is coming on, to be able to understand how to deal with the unavoidable problems of life. Got a bad message. Life has problems. We live in a society that tries to tell us everybody should be happy. I don't know where that comes from. You can be happy that you dealt with your problems well, but there are going to be challenges. So, okay, the 4 steps, I think they are required. I will go to the point that says you do a shortcut on any one of these and you're almost guaranteed to relapse. So let me summarize them again really fast because they're that important. You got to be committed to stop. You got to 100% remove withdrawal symptoms until the brain is 100% recovered. If you do it before, and I'll show you a graph in a sec that I drew for you, it's going to be the same problem. Correct the psychiatric triggers. By the way, it's just not that hard. You know, I'm not trying to go yay medicines, but bottom line, a good psychiatrist, and sadly not all psychiatrists are good, but a good psychiatrist has an incredible armamentarium of medicines that, when used properly, make really substantial changes quickly. And, you know, it is my expectation I help my patients get better. It's the rare situation at this point in time when I can't do that. Oh, I think I'm pretty good, but I don't think that's in any way special to me. And then, of course, that whole issue, you've got to deal with have to have better coping skills. Because, oh, by the way, any of you who have used know, when you finally come out of it, you have created one mess of a problem. Not only did you, Reverend Joe and I were talking about this earlier, you pretty much stopped growing and maturing when you started this, but oh, you messed up everything in your life, and a lot of people don't know what to do with. And oh, by the way, nobody trusts you because you've lied to everybody. And you're just going, but I'm telling the truth now, and they're going, yeah, right, I'm going to believe it. So you've got to have, you especially need coping skills right out of the box. Okay, as I said before, there's no single program that's right for everybody. You know, if your faith is very important, you should have a significant faith component in your program. If it's not important to you, you probably will resent that. My message is just make sure these 4 pieces I'm telling you about are in some form or fashion represented there. I don't care what the rest is. I care that it matters to you. I care that it resonates with what makes sense to you. Because if that doesn't happen, I'm sorry, you're going to relapse. And oh, by the way, this ugly little thing. A lot of these people that we hear about, unfortunately all too often, who overdose, let me let you in on something. A good percentage of those are suicides. And the reason they're suicides is if you go out and you've tried to stop, tried your darndest to stop, you truly were committed, but maybe went to somebody who didn't do the right things, and you relapse because they didn't really shut down your withdrawal, eventually it's natural to conclude that you're untreatable. And when the day you come to the conclusion that you're not treatable, boy oh boy, another 40 years of this doesn't sound real appealing. And the idea of suicide is very appealing. I know that may sound dramatic. I can't tell you how many patients said to me, you were my last stop. Coming here was my last stop before taking a lethal dose. We don't talk about it because you can't, how do you really prove it? And it's also a very ugly concept. Like I said, choose a design that works for you, but make sure those 4 components are at least in some way part of that design. Now, granted, this is not true for all addictions. If you've got a cocaine problem, you got a marijuana problem, very different physiologic issues that are going on with opiates. But still, more or less, so don't not withdraw, but just read it as you got to deal with the physiologic component. If there's no physiologic components, you got to deal obviously more heavily on the behavioral component. Okay, there are no shortcuts. If you take a shortcut, bad news, your chance of relapse goes up almost to the point that it's guaranteed. These are, from what I see, are some of the most common problems that produce relapse in opiates. Here's that one I keep talking about again. You're not ready for treatment. If you're not ready for treatment, you're going to sabotage it. You're going to be sneaking. Your thinking's going to be bad. You're going to be in withdrawal. Withdrawal, by the way, is a miserable experience. My belief, unless you have no choice, you're in jail, unfortunately there's a lot of drugs, or you're on an island where there's no drugs, just about nobody beats withdrawal. You know, it's not a matter of being tough, it's that nasty. And you've got to basically, like I said, I keep saying, 100% stop the withdrawal, because otherwise it wins. Okay, how do you feel good? Now I'm going to try and educate you. This is a part where I'm going to try and answer questions that I get put to me all the time, or even worse, I hear people's interpretation. I'm going to try and set the record straight. How do you feel good and be productive during recovery from opiate use and abuse? Oh my God, I just got a promotion. How am I going to handle this without getting fired? Guess what? The reality is you can be productive and look fine and think clearly tomorrow. It is that doable. Okay, so it's possible to feel that good. I tell my patients, they don't believe me until they experience it, but most of them are desperate enough that they'll at least try it, and then they come and go, oh my God, I wouldn't have believed it. 3.5 hours is what it takes me to get somebody who, they have to be in the early stages of withdrawal, to get them back acting like they were before they ever took their first opiate. I can do it 100% of the time. Not because I'm so special, but because I'm respecting what needs to be done in the brain. I'm going to tell you how we do that. Yeah, I'm getting tired of hearing me say this. Don't use or you're going to relapse. We'll just shorten that part. Okay, here is the way you as I said, there's only, you got to stop the withdrawal 100%. Right now, current state of medical physiologic art, there's 2 ways to do that. I'm biased. I'm a Suboxone provider. I could be a methadone provider if I want to be. I choose not to be. I do use methadone for severe pain at times. But for withdrawal, I don't. I think Suboxone is the best way to do this, because I'm going to explain it, and I know anybody who's researched it has seen horror stories about Suboxone, about why it doesn't work. I'm going to try and give you the reasons why Suboxone doesn't work in those cases, and hope that you're going to realize that it is probably, at this point in time, the best path out. I'm going to try and contrast it to methadone. Does methadone stop withdrawal? Yeah, it does. But it's the second word in the program, methadone maintenance. That's the key. Methadone stops withdrawal because methadone doesn't produce as much tolerance at the receptor level as opiates do. So you don't have a worsening. So you give a person enough methadone until things null out and they don't get any worse.